28-year-old female presented with complaints of diminution of vision in her right eye for 10 days duration. On presentation, she had a visual acuity of counting fingers close to face. On examination, she had vitritis with retinitis patches seen peripherally. She also had retinal detachment, which was seen in the infranasal quadrant. AC tap was taken, which came out to be positive for herpes simplex virus. She was tested negative for HIV and other investigations were normal. She was started on oral acyclovir. 3 days following initiation of treatment, vitritis started to reduce and the lesions were more evidently seen. The patient was planned for 25-gauge pars plana vitrectomy with silicone oil tamponade. 3 standard pars plana ports were made and core vitrectomy was started. Triamcinolone was injected and a general PVD induction in a sequential manner was done starting from the temporal quadrant and was done up to the junction of healthy and the necrotic retina. Adherent hyaloid over the detached retina was carefully removed. A retinotomy was made infranasally and the fluid drained with a soft tip cannula. Fluid air exchange was performed. Once the retina was completely settled, a 360-degree endolaser was carried out at the margin of the necrotic retina. Silicone oil tamponade was given and the ports were closed. On postoperative day 7, the retina was attached and visual acuity was counting fingers 3 meters. At a follow-up period of 2 months, the patient had a visual acuity of 6/60 with attached retina. This is another case of retinal detachment in a one-eyed patient. After passing a 240 band, a pars plana vitrectomy was started. There was a total narrow funnel retinal detachment seen intraoperatively. Core vitrectomy was performed and a general PVD induction was done with the cutter. Triamcinolone was injected and a complete posterior hyaloid removal was ensured with the help of a scraper. A peripheral sieve-like retina was seen 360-degree. A pars plana lensectomy was performed. Peripheral vitrectomy was done with the shave mode of the cutter. Intravitreal forceps were used to remove the adherent membranes. PFCL was injected to stabilize the posterior retina and more of peripheral vitrectomy was done. The peripheral sieve-like retina was cut 360-degree. More PFCL was injected and the retina stabilized. A 360-degree barrage laser was done in 5 to 6 rows. Chandelier assisted direct PFCL silicone oil exchange was carried out and the ports closed. Patient achieved ambulatory vision in the postoperative period. Several studies have shown that with the advent of 25-gauge pars plana vitrectomy, excellent anatomical as well as functional outcomes can be achieved in patients of viral retinitis-related rheumatogenic retinal detachment. A retrospective study conducted in patients with ARN-related rheumatogenic retinal detachment managed by pars plana vitrectomy and scleral element concluded that the functional outcomes were dependent on the status of macula and optic disc. Another study done in patients with CMV-related retinal detachment also concluded that with 25-gauge vitrectomy, excellent reattachment rates can be achieved in these patients without significant intraoperative and postoperative complications. Thank you.